Okay, folks. Well, delighted to have Kyle Kiser with me on today's podcast. We hopefully I did not slaughter your last name, Kyle. I said that correctly. Okay, good.
You
I'm known
nailed it.
to sometimes mispronounce and misspell names, but it's pleasure to meet you on this podcast. So hopefully, I get a chance to meet you in person. I got to learn about what you are doing by my own interest in big data and how really things can help patients and physicians alike. But before we get started, maybe a little bit about you. Just tell us a little bit who you are, and I mean, you've started this venture. How did this really come about? And tell us a little bit more.
Sure. Yeah. Personally, my background is largely been in payer-oriented digital health. So I worked for employee benefits and payer type companies straight out of college and had an experience working inside of the places. Uh, and went to work for Principal Financial Group, who had a wellness company that was almost kind of like an internal startup inside of the big financial services and health plan business. And that was sort of where I got my bug to try and do something about the rising uncontrollable cost of healthcare. It was just good environment, good experience, working with great people. From there, early employee at a couple of startups, WellTalk and Kettle Health. Uh,
So you started on the payer side. Like, what did you do on the payer side before you formed your own company? How did this all come about?
So I worked for health plans, worked in the employee benefits business. My family's business was employee benefits broker. So I kind of came up in that world, seeing the rising costs and what employers are facing and how they try and support their employees. But it's you really only have two options when you look to control costs. It's shift the cost onto the individual, or shift the cost onto the employer from a commercial perspective. Right? There weren't good options. So wanted to look to the innovation world and sort of see what you could do differently in healthcare. So early employee at WellTalk, early employee at Catapult Health. Both of those were kind of startups at the time. WellTalk was focused on consumer engagement. Catapult Health was primary care at the work site. Both great companies, great management teams. Got to learn a lot from good entrepreneurs, and wanted to give it a try as a early near day one, kind of joining a company. So joined what was then RX Review at the time. We've recently gone through a rebrand, and I'm in year 9. So we've just had my 8-year anniversary after the first of the year.
When you first started, were you running the company at the time, or you started doing something different and then you became the chief executive officer?
I started selling. Yeah, I joined because we had a collection of co-founders, and some were product oriented, some were clinically oriented. I was the guy that had sold stuff in healthcare before. And some of the background on the team is important story is Kevin O'Brien, who's was our sort of founding clinician. He actually started doing all of this work. The spark of this company is because of what Kevin was doing in his clinic. So he started to accumulate these ways to save on medications as his own initiative because of his own motivation as a clinician, seeing what people were facing from out-of-pocket cost perspectives when he was writing prescriptions. And that was inspired by his mom approaching him and saying, I've got $600, $700, $800 out of pocket in chronic meds, and how can you help? And so, like any good son with the skill set to solve that problem, he said, I could take this brand and break it into generic parts. You could pill split this one. There's 2 therapeutic equivalents for this one, and he cut her spend in half. That's really what motivated him to start doing this for patients. We took all of that initial effort and turned it into what is the inspiration for what has now become Arrive Health, and it's been because, in our view, it's the patient-provider relationship that's the most leveraged opportunity to create change in healthcare. Patients want that information from their provider. That's where the trust resides. That's where the care originates. That's where the decisions are being made. So how do we start to inform that moment with real-time, patient-specific, moment-in-time specific information around cost, so that what's effectively a purchasing decision can now be informed by information that's more familiar to every other e-commerce experience in your life, right? It's how much does it cost, what barriers exist, and how do you solve this problem?
So your overall, just to summarize this for listeners, your overall goal is what can we do to reduce the out-of-pocket costs for patients, receiving medicines, regardless of the diagnosis. I come to you and I have 10 medicines I'm taking, and your role is to work with me and to work with my practitioner to reduce the cost.
Thematically, yes. The way it works today is we are an invisible component inside of the EMR system, evaluating the prescription decision as it happens. So when you as a clinician go to prescribe a medication, so in your world, it's probably more often than not oral oncology agent you're trying to prescribe. Once you pin that med, we evaluate it. We send it out to the appropriate health plan or PBM associated with that member in our network. We get back real-time, patient-specific, moment-in-time specific pricing for that individual. And then if there's a lower cost alternative, then we generate an alert to the physician that says, hey, you were going to select drug A, think about drug B or pharmacy B. And so it's a OEM component of the EMR system now. We work with Epic, Cerner, and Athena, and several other smaller e-prescribing and EMR systems, but those are sort of the big three names you'd know. And we're the data network that powers that feature inside of those systems.
So you're integrated into the system where if I'm prescribing, I get more transparent alternatives that might actually help me change my prescription. How often do you see physicians changing the prescription based on your recommendations?
Pretty often. I mean, it's largely dependent on whether it's a pharmacy or a drug alternative. And so that's pretty variable. I think the pharmacy alternatives are actually much better adopted because there's no controversy there, right? It's just, this is a lower cost option from a pharmacy perspective. It's better aligned with their benefits. So that gets into the 30s and 40s% of the time. The drug alternatives are, it's almost too hard to generalize. But 20-ish% of the time there's good options. One of the things we've done some research on recently is almost 20% of the time there's a $0 option available. So we're doing 100 million transactions a year now, nearly, and almost 20% of the time there's a $0 option, and the prescribing choice was made for something $50 or more, and that's not the physician, that's not the prescriber's fault. It's just there's going to be some complexity inside of each health plan's preference, and that's not easily communicated to the point of care. So what we're doing is saying the right information is out there, the affordable option may be out there, let's go help find it for the provider so that they can bring it forward. If it's therapeutically equivalent, it still accomplishes what they want to accomplish, we're solving that problem the first time rather than them getting to the pharmacy counter, finding out they can't afford it, calling you back, going through that whole process.
Isn't some of these decisions, aren't some of these decisions dictated by payers? I mean, in other words, you obviously came from that world, and a payer sometimes might dictate you have to use drug A versus drug B because I get rebates or I get whatever, let's face it, some kickbacks from the manufacturer, however you want to call it, let's call it rebates. Or sometimes even they dictate on you the pharmacy that you have to use because of these contracts. How are you able to navigate that?
Yeah, we're communicating those things up front to the prescriber. So albuterol is always a good example, right? There's half a dozen ways you could prescribe albuterol. It could be a disc, it could be an inhaler, it could be a nebulizer, any number of things. And one of those is probably a $0 option for that patient, and the others are probably $250 a month. And as the prescriber, you have no idea, but probably don't have that strong of an opinion, right? Like between the disc and the inhaler, those are more than likely equivalent options. So our value is we're communicating those things up front so that it's not a mystery for the prescriber, that they can know that there's a $0 option out there. You can get the patient on it and solve the provider's problem and the patient's problem at the same time.
So how do you make money? Do you make money because you're selling the software into the EMR? Like how do you generate revenue?
The health plans and PBMs pay us to represent their information in workflow. We have some decision support capabilities for health system pharmacies. So in those cases, health systems pay us a subscription fee to generate health system pharmacy options where they're affordable and in network. And then most recently, as of the first of the year, we just acquired a virtual assistant capability from UPMC, where it's a chatbot that reaches out to patients after the moment of prescribing and works on adherence issues and compliance with medications. That's a health system paid subscription based model that is direct to patient. That's our sort of first step into direct to patient communication.
I see. So then do you aggregate the data that you get from either prescribers' use or the physician's use, and you're able to bring that back to the provider to optimize care? I was just seeing on your website a lot of how you actually take the big data and you use that to optimize care. And what kind of data that is helpful in this scenario?
From a de-identified aggregate data perspective, primarily we're using that to make the system better. So how do we generate alternatives that are more relevant, more clinically relevant and relevant to the payer preferences? And how do we generate better behavior change associated with lower cost options for patients? That's mainly for our own use at this point, not something that we're necessarily commercializing it with third parties. It's just to make the system better.
So I mean, I'm thinking, so as somebody who took care of patients for a long time, it seems to me it's a no-brainer. If you come to me and you say, I have this, it seems like it's a no-brainer. I will benefit from it and I will really help my patients. What's the pushback that you get when you go into healthcare systems or practices and they say, that's not really for us? Like, why wouldn't they?
It's usually just prioritization. I think the biggest challenge that health systems have that we hear, especially when integrating with EMR systems, is that the line of things to do to those EMR systems is long and distinguished, and the amount of resources to do that work is continually constrained. So we don't actually often, maybe ever, get, no, this is not something we want, or no, this is not a good idea. It's more of a, I've got to do my upgrade for my Epic system, or I need to, go through some compliance process for cures. It's meeting those sort of regulatory bars that often stand in front of us and keep us from being well adopted. But it's adopted pretty easily. I think your perspective is the one we hear the most, which is, this is a no-brainer. This is the way it should be. We want to take care of patients. This is going to save us time. It's going to save the patient money and time, and ultimately the right thing for the payer and PBM too, right? Because every time they have to do a prior auth, they have to put something to a clinical review, that's expense for them. So this is definitely one of those win-win-win.
Does it like help with, like, I can tell you, prior authorization, Kyle, is one of the most pain in the neck in the ass that ever a physician should have. Okay, tell me that your solution is minimizing prior auths, please.
It does. We call it avoiding prior auth, actually. So there's a lot of times where a prior auth is required because there's another medication in the class or a therapeutically equivalent medication that doesn't require prior auth, right? So there's often the case that we help you avoid the prior auth altogether, so you don't have to do it, right? And that's the perfect scenario. So part of the problem with prior auth as it exists today is largely the first step in a prior auth is, what are the requirements, right? Like, I need to understand what payer that patient's associated with, the group and plan level information. So the way that group and plan level information right now gets into the EMR is through flat files. So the plan sponsor sends it to the health plan, so who sends it to the PBM, who sends it to an intermediary, who then calls the EMR system and says, hey, download your file, and then they do that once a month. And so even when that process works perfectly, that data is stagnant, right? It's out of date. And so this is a real-time process. So today, based on what we know about you, your insurance, your pharmacy, we're going to send that transaction and figure out if that prior auth is actually required. You may have already satisfied prior auth. You may have a pending prior auth. There's a bunch of scenarios where that may not be required at the moment. So the transition from old flat file transfer to real-time patient specific is part of the bigger prior authorization problem. And now being able to communicate that there are options that don't require prior auth gives you as the prescriber the opportunity to avoid it altogether. But we entirely agree. We're also doing work around prior auth automation with EMR. We're doing that right now with University of Colorado and UPMC in Pittsburgh, and see a lot of good opportunity just to make that process better in workflow. Largely, even electronic prior auth is a retrospective process, meaning it was generated by a denied claim. So, dealing with those things up front is absolutely our ambition and something we're working on actively.
There's a lot, you probably heard this, and I'm actually doing a podcast on this, on PBMs and pharmacy benefit managers. They're not really too, there's a lot of angst amongst the provider side and about the physicians about pharmacy benefit managers, because in the views of physicians, the PBMs are this intermediary between health plans and patients. And technically, they were supposed to negotiate on behalf of patients with the health plans and manufacturers, whatever it is, to reduce the cost to patients. But there are so much written out there that they have not really done so in terms of reducing the cost of healthcare from a patient perspective. What's your sense of the need for that intermediary? Give us some historical perspective. How did this all start, and why do physicians really not like PBMs?
Well, I think, at the outset, right, the idea behind PBMs is, let's see, what was the High Tech Act? 95, I guess, is when the High Tech Act passed, which is what made PBMs come into existence. And the thought behind PBMs is aggregating demand, so that then you have an ability to negotiate on what was constrained supply on the pharma side, right? And so, in general, that is absolutely necessary, right? Like an aggregated demand to drive down costs is just a market force that's required in our system. Now, through consolidation, right? It's been aggregated to a huge degree, and they keep, through the verticalizing of healthcare, it's hard to say if even the PBMs are negotiating with payers. The PBMs are payers, and the payers are PBMs, and they're all more than likely the same organization. In general, the function of negotiating on behalf of patients with market power is needed. There's a bunch of ways that could be different or better and more transparent. But our goal is really connecting the right information with the decision makers at a time where it can be acted upon, right? And that, to me, even in the existing structure, changing the existing structure may be a worthy ambition. Not something we're going to try and tackle right now, because there's plenty of work to do and just trying to get the right decision made at the right time to help a patient today. Because, frankly, the biggest change that really, everybody likes to talk about healthcare economics changing, and like, will there be single payer, or will there be some reform, or what does Medicare Advantage do to the overall system? What does the aging population do to the overall system? Well, the change that's already happened is, over the last 25 years, consumer-driven healthcare is the way of the world. The average deductible is, well in excess of an individual American's ability to afford it, right? We're talking, the average deductible is probably $2,500 now. So we've already shifted the cost on the backs of patients without giving them the tools to understand how to make a market-driven decision. So our goal is really just to start introducing consumer choice where those decisions are happening. That's at the point of care, and that's in the hands of patients. And we got to give patients the tools to make better choices. There's lots of work to do on making the system itself work better overall, but as we battle over those very worthy and important issues, it's, half of Americans can't bear an unexpected expense of more than $1,000 without facing bankruptcy. Yeah. So our goal is just to connect them with the right resources and solve their problems.
I like that. I agree with you. I think that if we wait until we solve the systemic issue in healthcare, patients will not be serviced. And I like the idea of providing patients with choices and physicians with choices. What do you do? I mean, I'm a medical oncologist and I took care of cancer patients for a long time. And I think there's probably little flexibility with some of the choices that you have when it comes to cancer care. Although I
Yeah.
admit that there are some Me Too and Me 3 drugs right now. You have the same drug for the same indication for the same disease. But in scenarios where you don't have alternatives, what do you do for these patients and physicians?
Oncology is a little bit out of our purview often because we're really embedded into the e-prescribing flow. And a lot of the prescribing for oncology happens inside of decision trees and decision support tools that are not in the traditional e-prescribing flow. So as those orders are queued up in the ERX flow, so the oral oncology agents, we're probably able to deliver some value there. To your point, there's not a lot of alternatives from a drug perspective. But where you fill that medication usually matters a lot. And that might, maybe significantly less expensive to use the health plan or PBM owned pharmacy in those scenarios. And where that's true, we provide that as an alternative. Also, there's usually a lot of really good reasons to use the health system owned pharmacy, especially for somebody that's in such a complex condition. And so where the health system pharmacy is an affordable option in network, and we help promote those as well, so that providers know, you can keep it in the system, keep the data consolidated, have an integrated experience. We do both of those things.
And then what have you noticed, like based on your observations and based on what you have done over the past several years, where are you seeing the lowest hanging fruits when it comes to prescribing, where you see physicians prescribing something, but there are clear alternatives that they were not aware? Like, are there some lessons learned that you've seen over the past several years that were, either surprised you or might surprise me?
The $0 option thing really surprised me. The fact that almost 20% of the time there was a $0 option that the physician was not aware of. That was a big surprise. I think the other surprise is just how often the right answer is shifting, right? If you think about a clinical day for a provider, they're going to see, probably in oncology, you're seeing fewer patients, but average primary care doctor is seeing 20 to 30 patients a day, right? And for those 20 to 30 patients, if there's 4 or 5 different insurers in that market, then that becomes a really complicated thing to keep up with, right? Then there's pharmacy benefit carve-outs, and then there's different, sort of changing negotiations that happen within a health plan or a PBM, so that for those 20 and 30 patients, you may have 15 or 20 different answers for what is the right alternative for this patient. And just because it's a Humana member or a United Healthcare member doesn't mean that you know the right answer for every Humana member or United Healthcare member, right? Different for commercial, it's different for Medicare Advantage, different for Medicaid. And so to me, it's that this is like a never-ending problem, right? Like, it's not that I kind of wish we were in a scenario where the system would be so effective that doctors would just start to know what the alternatives were. But the fact is, it's a really complicated problem. It's an ever-changing problem, and it's something that technology can and should solve.
Yeah, it remains interesting to me, the $0 option. I mean, certainly it is very surprising. It's a pleasant surprise to do that, and to even know that. And I kind of think when I'm listening to you, like I almost feel as if you're almost your entity, almost like providing financial counseling to patients at the point of care. Like you're almost there when I'm prescribing something. Instead of me sending the patient to the financial person in my office, there's some electronic methodology by which I get information that's going to help lower the issue for patients. I mean, I don't know. It just seems like this is how the metaphor I have, I guess.
No, it makes sense. It totally makes sense. Actually, here's another surprising one. Is this will require a little bit of context. So in order for us to perform a real-time benefit check, we need the eligibility information from the EMR, right? We need to know what insurance company they are affiliated with, so we know where to send the transaction. And 40% of the time that's just not there. That information is not in the EMR. And so 40% of the time we can't do anything about it, right? And so we actually have established now a network of cash pay and discount cards so that in that 40% of the time scenario where there's no eligibility, we can provide something of value as a provider and to the patient so that we understand how to solve that problem. Because, you know, this is from a user perspective, can you imagine something that only works 60% of the time? Like, how often do you feel like you're really going to start to rely on that if 60% of the time it works, 40% of the time nothing shows up? So we've started to fill in that gap with some cash pay information so that we get some sense of actionable pricing every time.
They're not available because these are uninsured patients, or because just they were not, the information were not entered in the EMR?
It's probably both. So some of that might be uninsured. That's probably not that many anymore. Some of those may be, you know, associated with a state Medicaid that didn't pay for e-prescribing, so that data is not there. Some of that might be the data lag I was describing, because that eligibility is still flat file process that takes files transferring from one place to the next. So yeah, it's a combination of things, but it was, I think, surprising to us that it's consistent. It's not an EMR problem. It's across all EMRs. It's not a payer problem. It's just the way we've decided to facilitate that data exchange doesn't work particularly well.
And all of this is obviously for commercial payers. Do you have, I mean, obviously Medicare and Medicaid is a completely different ball game, and you know, you've got Part D and other things going on with Medicare and all of this. Are there any solutions for the Medicare and Medicaid patients? I think Medicaid is probably easier, but I don't know. I presume everything we talk about
serve
commercial payers.
No, we serve both those markets. So actually, CMS 2 years ago passed a rule that required Part D payers to provide a real-time benefit connection. So now, if you're a Part D plan, you have to do the type of data exchange that we provide. Medicaid, not so much. Medicaid's pretty fragmented, as you know. We do work, you know, with several MCOs for Medicaid population. Presbyterian, New Mexico, which is a extraordinarily successful Medicaid payer, is a partner of ours. So yeah, we're across lines of business.
Yeah, I gotta ask you like a business question, just because I sometimes think of business, because I'm trying to think of other entities in the same marketplace that are doing the same thing, and I can't. It's, you know, I obviously I know that some payers have this internal, you know, they have their own internal resources, PBMs, and some practices they have these internal things. But in the marketplace, who do you compete with technically? Like, who are your top 3 competitors business wise?
On the real-time benefit front, we compete with SureScripts, who's kind of the legacy e-prescribing network, is probably who we run into the most.
Yeah, I mean, it doesn't. I mean, it doesn't seem that there are other. I don't know. I can't think of other competition. So this is big. You're trying to solve the problems pertaining to cost of care at the point of care with physicians. Any plans? Have you looked into inpatient care and the cost of care on the inpatient side, and you know, hospitalized patients as they accumulate copays and cost for their inpatient hospitalization? Is this another possibility for you, or not right now?
Inpatient's probably not our focus. It's kind of a whole different ball of wax. Discharge, absolutely. So you know, as someone goes through a transition of care, the medications they may have been on in patient may need to be different outpatient based on their formulary. That's something that is happening inside of the EMRs at discharge through our tools, but not a full transition to inpatient care. Not a focus of ours.
Now, have you ever thought when you were growing up you're going to be a CEO of a company? Is this something that you thought about? And what does a life of a CEO of a multi-million-dollar company look like? How do you spend your day?
Mostly on Zoom. or airplanes.
Or podcasts.
Yeah. No, to answer the question, I did not consider this as an option. You know, I sincerely was interested, willing, and running headlong towards being in the employee benefits business. That was what my dad did, and was headed in that direction. So it's quite a departure. I grew up in North Carolina too, so if you would have asked me 1,000 times when I was 12 years old if this would be my job and I'd live on the West Coast, I would answer no 1,000 times. But you know, could
So
be
what
surprised.
made you take on the role? Like how did this come about? Like what, did you think about, is this the right career move? Like, I mean, you've been on it now for several years. So clearly you obviously are making an impact and you made the right choice. Did you doubt yourself at some point that this is the right career move?
I honestly didn't think about it. I cared sincerely about the mission, right? Like we have this mantra around the company that's called it's Lucy Up is what we say to each other. It is because of that story I told you about Kevin, our founding physician, and him wanting to help his mom. His mom's named Lucy. And so we developed this mantra a long time ago that's this Lucy Up moment. And so whenever we need to focus on why we're really here, this is really about something bigger than ourselves. This is really about trying to accomplish something meaningful for people in healthcare. We can say Lucy Up to each other, and it all says that, right? And I absolutely believe that to my core. Like everybody's got a Lucy in their life. It might be them, it might be somebody you love, but everyone's had some experience with the healthcare system that just didn't make any sense or left them feeling disappointed. And frankly, I'm obsessed with that problem. Like it feels solvable. There's so many. Now there's the data access. Now there's broad adoption of EMRs. The claims systems are now capable of generating real-time transactions. The table is set to make this better. And so, for the first time, maybe ever, consumer choice in workflow, in clinical workflows, and consumer choice in the patient experience is viable. And so I'm obsessed over that problem. I could care less about what that does to my career.
I think that I think it's a big problem, and I really what intrigued me about what you're doing is that you are attempting to have solutions, and I think we need solutions. So I'm always grateful to anyone who is trying to solve these problems. What's like how big is your company currently? How many employees?
After the acquisition, we're 73.
73. And how do you see things evolving in what you're trying to do over the next 5 years? I ask because I feel that there are certain uncertainties in any marketplace. Obviously, some of it is political pressure, some of it is regulatory and other things. But I think that I'm curious, as you think about who you're going to be targeting and who are the physician practices and networks. Basically, how do you go around this? Like the sales forces go and meet physicians and hospitals, and who do you talk to? The CMOs, the CEOs, when you go into a healthcare system, who are you facing?
It's a combination. We're often talking to pharmacy leadership. We're often talking to a CFO, and many times CMIO, just because of the user experience of the EMR is really important. That's kind of the three legs to the stool more often than not.
Okay. Yeah. Well, look, I think it would be great to see how you evolve and how things are actually progressing nicely. What other things you want to share with listeners I may have completely forgotten to ask you?
Well, I guess that the other part of your question I didn't address is that sort of 5-year vision. I think ultimately in 5 years, well, let's talk about where we are, right? Like where we're coming from is patients don't know where to go for answers. They go back to their doctor, and through no fault of their own, the prescriber does not have the answers, right? Like they don't know necessarily how to direct you to your health plan or know how to direct you to a hub to solve some affordability issue or enrollment form or whatever. So to me, 5 years from now, that we're arming providers with automation and technology to where that is a seamless part of the way to deliver care. Because that, back to that consumer-driven healthcare reality, patients are faced with, in many times, an unbearable cost burden, and they don't have a lot of tools helping them solve that problem. So 5 years from now, we want the providers to be armed with the technology and the tools to where they can help solve those problems for patients without overburdening them and their staff. That's ultimately what we're trying to accomplish.
And you went on the record. You said there will be no more prior auths. I know, Kyle. I heard that.
There are probably several scenarios where that might be possible, but I don't know if I can make that promise.
Yeah. It's interesting. There's also in a lot of practices they have the clinical pathways. In terms of how you do this. Have you thought about being integrated into these clinical pathways based on the insurance and the data information that you have? In other words, you're already versus after the fact, you're part of the pre-work type of thing. You're part of the pathway type of thing.
Yeah, actually, the initial product we built was a decision support application and workflow. We were incubated inside the University of Colorado Health System in Denver. We work closely with their Care Innovation Center. And our goal was to build a user experience where in one view and through one click, a doctor could see clinically appropriate recommendations and the cost of associated clinically appropriate recommendations. And we built it. We built it for antibiotics, not because the cost of antibiotics is particularly unbearable, but because the antibiotics had a discrete yes or no, right? Based on the antibiogram, there was a right and a wrong answer, and we could measure whether or not we were driving behavior change through sort of like the one-click order type scenario. And that's still, I think, that's the killer clinical app, right? If we can unify clinical recommendations with cost recommendations in that sort of pathway tool, I think that's absolutely what we should be driving towards. And to your point about prior auth, if that tool is in the world, then anybody who uses that tool shouldn't be subjected to prior auth, right? Because you're going through the pathway that's recommended by the payer. And so it should be kind of that gold carding scenario where if you're using this tool, then you shouldn't have to go through a prior auth process, which is technically possible today. You could be indicated as a gold card prescriber at a PBM right now, and you wouldn't have to do prior auth because they would trust that you're going to make the right decision. So I think that's absolutely an inevitable future, and whether we'll get there in this business or not is to be seen. But we've had such extraordinary growth on the price transparency and real-time benefit side that we haven't done a lot of work on the clinical decision support side because we've been keeping up with that growth. But I think that's absolutely the right approach.
It's a big opportunity, honestly, and I think you probably have the tools and the expertise to be part of that. And it will be really very much welcomed by a lot of physicians and practicing physicians. So, Kyle, thank you so much for spending some time with me. I enjoyed really getting to know what you're doing and what the company is doing, and I hope that folks can check out Arrive Health and check out your website and the opportunity that there if they are on the provider side and whatever it is that that you're doing. I hope that you can come and visit with us again in about a year, and we can talk about the progress you've made.
That sounds great. I'll look forward to the invitation.